That most of you know Jeanmarie Perrone. I am a great admirer of hers because she has used her career in a way to really move the needle in an area that is so huge and at times has been so frustrating. I'm not going to read her bio, but I will say that she is a founder and an initiator and just an amazing entrepreneurial person about her career and about what she's passionate about. So I'm going to turn it over to Jean Marie.
Thank you, Lucy, and thank you to the Focus team for inviting me to be able to share some of how I've gotten to where I've gotten to, what we've accomplished, and how the role of advocacy in many ways has really shaped the work that I do. So thanks for joining. Um, I'm just going to share a little bit about my background. I did an emergency medicine residency in Philadelphia, and for many reasons, I chose to do a 2-year fellowship in medical toxicology at Bellevue. That at the time was a place where a very important mentor of mine, Dr. Louis Goldfrank, had really founded the field of medical toxicology, otherwise known as poisonings and overdose management. In that time in New York, I really learned a lot. I was really excited about the work and sort of creating, being a medical toxicology expert and being able to be a consultant and kind of help people through acute poisonings in the health system. And after my training, I came back to Penn as an assistant professor of emergency medicine in the clinician educator track, which was a little different than it is now. But essentially, that gave you a little bit of protected time, primarily to educate and be a teacher. I came back here. I actually importantly came back in fellowship. I met a another person who was in the fellowship who was also an emergency physician, medical toxicologist, and we came back together and got married. So that's kind of an important part of the story. My husband was also in the same department as me, which actually took some advocacy even to get hired because my boss was not interested in having a couple working for him in a relatively small department. And so we had to kind of lobby and agree that if things didn't work out, one of us would leave. So that was kind of interesting and probably maybe not exactly legal. But anyway, in that era, poisoning deaths were actually declining. So we had made medications more safe. So things like blister packs, poison prevention education, improvements in resuscitation outcomes had actually led to a decrease in overdose deaths to less than 100 per year. And so that was really a big win. My role in the health system was really just to be a tox teacher. So I had a great niche. Nobody really knew what my husband and I knew. People would call on us, but there was really no opportunity to start a consult service or to really advocate in the hospital because the doctors here were a lot better trained than some of the people in New York had been. And so, we were sort of the experts when there were some rare poisonings that people needed help with. So during that era, I published many case reports and few studies, but enjoyed my time as a toxicology educator. I was also starting a family, and I had 2 kids. It was sort of in that survival mode. My husband became the residency director, and so we took advantage of a lot of things that Penn had. We spent a lot of time with our kids outdoors. When we had conferences, we would both go. We would bring the kids, we'd bring some in-laws, and we would make it a trip for the family for a couple extra days to kind of integrate our work into our family life. We also were able to take advantage of the Penn program in Botswana. We spent 2 months working in a Botswana emergency department when our kids were young. We homeschooled them. We got a lot of support from their, public elementary school that this was more valuable than keeping them in kindergarten and second grade. And so, just taking advantage of these things, even though it seems like a monumental task, it was really impactful on our kids and our kind of sense of self going forward. And then, as I said, my husband was the residency director. And so the residents were like our other family. They were frequently at social events with us. Our children were often with us. And we hosted this journal club now as our children were, more middle school age, hosted a journal club at our house. And one of the residents had chosen the articles, and it was about how a prescription drug monitoring program could help identify patients who were doctor shopping. Might seem impossible to think about that in our current era where we're very aware of opioid prescribing and overprescribing. But at the time, we actually had very few tools that were available to find out if a patient was at Mercy Hospital, half an hour ago getting prescriptions for back pain and now was in our emergency department. So together we started, working on the problem of opioid overprescribing, and we collaborated on several different initiatives. But one was very easy. We wrote a perspective article, which was actually accepted at JAMA. Hallam at the time was a resident. And, we just said that, the position of emergency physicians is there's no chance that we will be able to understand, everything about our patients' primary care, experiences with drugs, et cetera. But a prescription drug monitoring program would be able to help. And at the time, Pennsylvania didn't have one. We also joined the I'll call it PDMP task force for Pennsylvania that was going to implement one, which took about 5 years from this article, but was kind of the first piece of advocacy that was not that difficult to put together and was really ultimately quite impactful. At the time, we also had patients in the emergency department who would come in with, say, abdominal pain. They'd wait a few hours to be seen. They'd get an abdominal CT that wouldn't really show anything, and we'd be ready to discharge them. Good news, you don't have appendicitis, you don't have this, you don't have that. And they'd say, well, what about my pain? And we would actually dispense, it was often in the middle of the night, a 4-pack of oxycodone. And this 4-pack, was supposed to help them get through the acute pain. And then, they were going to follow up with their doctor. We generally weren't prescribing a lot of opioids, but dispensing this 4-pack kind of led to its own life of its own, where the year before we started our initiative, we had actually dispensed 7,000 4-packs. So nobody was really watching all of this. And so we began to educate our prescribers that, that we could, achieve the same thing with other things, other medications, and that it wasn't really necessary. And, began to educate to patients that starting oxycodone for a painful condition could also often lead to chronic opioid use. So we became much more cognizant, spent a lot of time teaching colleagues this. Now, this might seem, obvious at this point, but this was going against the grain of the Joint Commission and everybody else who was recommending, pain score of 10 out of 10 should equal, the highest, most rapid achievement of pain control. And that often led to opioid use and sometimes opioid misuse. So this was the forefront of beginning that education. Around the same time, there was an article that was published about which specialists were prescribing the most opioids. And emergency medicine ended up on that list in all age groups. And, we really felt that we weren't doing a lot of prescribing, that we often used opioids in the emergency department for acute pain, but that it was a lot of other groups that were continuing them for chronic pain. So that led to 2 initiatives. One was let's prescribe, let's give people ibuprofen and not IV Dilaudid in the emergency department. But it also helped me and others form a collaborative of emergency physicians across the country who wanted to describe what our opioid prescribing was for and in what way was, for what indication. So I could never have done this alone. This was one of the first multi-site collaborative ED studies that I've been involved in. And it was really just a starting point, but I really learned how much you can benefit from working with other people who had better research methods training and other people, everybody doing a small piece of a big project with a good project manager can actually have projects started and finished, which is, of course, a big lesson in academia. So again, as this re-education of prescribers was occurring, we had these few publications. I became available to our state as an educator about opioid prescribing. So I ended up on some state guideline writing committees. This is a very easy thing to get involved in. I write some things for various organizations now. They always need more people. This often is just a committee seeking members, so it's not something where you need a whole lot of qualifications for, but it can open a lot of doors in a way of lending your expertise and your time to get a publication that occurs and is often frequently referenced. So this was an important way of getting people to understand how to not use opioids in the emergency department. So, along the lines of all of this work about what I call deprescribing opioids, concurrently and maybe related, maybe not related. There began to be an opioid misuse crisis, and that's morphed into where we are today. Philadelphia continues to have one of the highest overdose death rates in the top 10 cities in the country, and as you know, we still have kind of record-breaking overdose deaths every year. So just to take it back to a clinical scenario, around 2015, we would increasingly be seeing patients coming to the emergency department either in cardiac arrest or after an overdose. We get an alert, what's called a haste message where they go over the loudspeaker in the whole emergency department, 25-year-old male, code in progress. The care standard in emergency departments in 2015 was that, he would get naloxone or Narcan in the emergency department. He might wake up and be fine. He might even be able to be discharged. But the only thing we could offer him at discharge was, you should stop using drugs. You may die. You just had an overdose, but nothing to actually prevent the next overdose. And in subsequent data, we learned that 1 in 12 will return as a fatal overdose within 1 year after a non-fatal overdose. So that mortality exceeds the mortality of ST segment elevation acute MI, which we actually spend a lot of time in the hospital, in the front doors of our hospital, doing an EKG on every single patient to make sure that we don't miss this disease that actually has much lower mortality than the number of people who come in after an opioid overdose. So currently, our standard of care has changed drastically in the past almost 10 years. So now in a patient who comes in post-cardiac arrest, most likely they got revived with naloxone in the field or by a bystander. We have tried to saturate the community with intranasal Narcan sprays. And so it's actually quite routine that a patient will have been revived by a bystander. We have substance use navigators in our emergency departments who can support the patient, as they come to. And we've also been involved in a study where we take blood samples from the patient to find out what they might have overdosed on. So beyond fentanyl, there's many other things in the drug supply, and we are trying to tune our management to what we discover from these studies. We also have completed a 4-year clinical trial treating patients with an injectable buprenorphine prescription or injection that lasts 1 week. So it's kind of beyond the scope of this talk to talk about the evidence basis for buprenorphine or methadone, but essentially, opioid use disorder is highly treatable. Both of those medications decrease the rate of fatal overdose by 50%. So when you can actually get a medication in that lasts a week, that's really impactful. We discharge everyone with Narcan. We have them meet with a peer for support, meaning a person with lived experience who can sort of shadow them on the journey if they're, trying to move forward, or to provide harm reduction education. We also try to connect them to some of our other services, including our telehealth service. We have many colleagues now in Penn primary care who are addiction boarded and who prescribe some of these medications. And can see these patients in follow-up. So really important components of treatment. So what changed in those 10 years? Well, first of all, we had to get approval from the Pharmacy and Therapeutics Committee to approve new starts of buprenorphine. Previously, it wasn't even on our formulary, so there was really no treatment. When patients got admitted to the hospital for complications of opioid use disorder, there was really no treatment while they were in the hospital. There was, we had to provide the evidence for why this would be important. We had to draft pathways for when and how to use it. At the time, there was the X waiver, which meant that all clinicians needed 8 hours of training in order to prescribe buprenorphine. So we needed to get a handful of people trained in how to prescribe. We had to work with the Penn PCPs to advocate for them to be interested in adding this to their practices. We had to coordinate warm handoffs so patients leaving the emergency department would be connected to peers who could help them get to that first appointment. We worked with a lot of nurse champions in the emergency department and peers to help address stigma amongst our providers. And then we needed to do a lot of harm reduction education and naloxone distribution. I will say some of the beginning of our naloxone distribution came from one of my residents who wrote a small grant to be able to dispense naloxone when it became available. And she worked out a very elaborate pathway where we could actually hand it to patients in the Presby Emergency Department. So never underestimate the power of Penn and how working with residents and nurses nurses can really enhance your reach. So at the same time, there was a study that came out with from colleagues at Yale that really put together the evidence that treatment could be started in the emergency department. So what they found was that if you start, if compare, so and there's three groups here. So three groups of patients. So for patients who were seen in the emergency department, whoops, after an overdose, if they were just given a referral to treatment, about 35% of them would follow up. If they were given a brief intervention, meaning some counseling and some motivational interviewing, a higher percentage. But if you actually started them on buprenorphine, about 73% of them were engaged in treatment at 30 days. So this was really important and really a landmark study that allowed us to begin the evidence for starting treatment from the emergency department. And again, this was sort of propelled a lot of the programs that we started in that same era. We also started a peer program. This was the core program out of behavioral health and at Presbyterian. This is Nicole O'Donnell, who still works with us very closely, is an amazing person in recovery who's been a wonderful advocate and still now manages a team of 20 peers and navigators who do this work across the health system. So another thing that we needed in order to get people to get those 8 hours of training under their belt, we advocated there was some state incentive money that was going to our health system for hospitals that were, meeting patients in the emergency department with better treatment initiatives. So we asked for some of that money to individually pay clinicians hourly for the 8 hour training. And so once we did a very brief incentive period of about 6 weeks between Thanksgiving and New Year's. And, it's sort of like holiday money for people if they did the training, which was all available online. That we then almost at this point, we had, when the X waiver was still required, we had about a 95% rate of the clinicians in the emergency departments being X waiver trained. So that really helped our ability to do this prescribing from the emergency department. And around that same time, I went to health system leadership and said, if your son or daughter was diagnosed with lymphoma, you would go to the website, the oncology website. You wouldn't know which of our amazing oncologists, would be the best person to take care of your 28-year-old with Hodgkin's lymphoma. But if your 28-year-old was diagnosed with opioid use disorder, you couldn't find a practitioner who offered this treatment in our health system. So the goals were to de-silo this care, create pathways, gain momentum. There were a lot of advocates in a lot of different departments in ID, in primary care, in emergency medicine, but there really there's no division of addiction medicine. It's not really owned by anyone. And to this day, that is still true. So we got together a bunch of advocates. This was multidisciplinary teams. I can see that most of those people are still involved, but a lot of people who, nurses, doctors, APPs, who really wanted to see some better care for patients who got into the hospital. So that started our program called the Center for Addiction Medicine and Policy. It was born in the fall of 2019. So COVID happened shortly after that, and we had to, revert a lot of our trainings and a lot of the care we were providing to low barrier online. So these are some of the programs we currently have. Again, if you go to our website, there's a lot more details, but I want to highlight a couple of them. First of all, when a patient is struggling with opioid use, they're living from dose to dose. So every 3 hours, they may use fentanyl again, or they develop withdrawal. So if somebody has a treatable moment, you have about 3 to 6 hours to stabilize some of their withdrawal treatments and get them into, a plan. Right now, SAMHSA has a helpline that's nationwide. So if you call this and you say, I want treatment. So I did this. I called and I said, I want treatment. I was just discharged from a rehab. I want to get on Suboxone. Oh, okay. Where are you from? What's your zip code? Okay. They transfer me. I get on the phone with somebody who is near my zip code and they say, okay, next Tuesday you can come in. You got to be there at 7 a.m. You got to take a number. We're gonna, get you do your intake that day. And I said, well, when am I going to get my Suboxone prescription? So, that'll be 2 or 3 weeks after your intake. So when you lose that, treatable moment, that doesn't really help anyone. So patients need medication immediately. So in the pandemic, we were able to, they changed a lot of the flexibilities around telehealth. And so we were actually able to prescribe buprenorphine over the phone. So we were actually doing this during the early parts of the pandemic, but we formalized this through something we now call the Care Connect Warm Line, which is a partnership with Penn Medicine on Demand. I don't know if you know, Penn Medicine on Demand is our virtual urgent care that Penn runs. That's really amazing, wonderful advocate nurse practitioners who, when your family calls you and they say, I might have a UTI, refer them to Penn Medicine on Demand. They can do all the hand holding, they can do all the prescribing. I have an earache, my kid has an earache, all the things. They're amazing. But they agreed to partner with us to create another pathway where they could see our patients via telehealth and do that first buprenorphine prescription or a follow-up prescription for patients who got started on buprenorphine in the emergency department. And, we didn't want to use everybody's primary care appointment visits and, book everyone up if patients weren't showing up. So most of our patients will get their second prescription from our telehealth line, and then they'll get navigated to an appointment, in person in primary care. So we are a bridge. We don't intend to be people's long-term solution, but it is a really important component. And at this point, we've served over 3,000 patients. And I can't advocate enough or thank my Penn Medicine on Demand nurse practitioners who did that X-waiver training, took this on, said this is really important. They see this problem in their community and they wanted to be part of the solution. So this has been really amazing. It's also supported by the Philadelphia Department of Public Health. It started with the 3 navigators in the picture. Again, we now have 20 people who answer the phone 7 days a week. So if you have a patient in the hospital, and I actually call them all the time myself and say, I have a patient, it was Thanksgiving Day, I had to prescribe buprenorphine. Which pharmacy is open and which pharmacy is friendly to buprenorphine prescriptions? And, my own navigator looked that up for me because I was busy in the ED. So they can answer every kind of question. The workflow is the first person who answers the phone is a substance use navigator, which is either a person with family lived experience or personal lived experience. They speak to the patient. They kind of do a little bit of, what are you looking for today? Do you want methadone? Do you want buprenorphine? If it's a person who's a good candidate for buprenorphine, they get them a telehealth visit within the next few hours, and then they help navigate them to that telehealth visit. And then after the telehealth visit, where they get an e-prescription for buprenorphine, our care navigators can help the patient get to a pharmacy. We can do the copayment if there's a copayment needed for their buprenorphine. And if it's somebody who wants methadone, we can help them with some generally next day intake at a methadone clinic. So it just really helps to have somebody answer the phone and, be a human and really support patients when they're having that treatable moment. So we've had to do a lot of advocacy at the state level. The public health emergency is what allowed telehealth prescribing of controlled substances to be sustained. Every 6 months to a year, we have to renew that, and we continue to advocate both at the state and federal level in order to sustain this exception to our previous controlled substance rules. I do believe that there will be permanent changes to this coming up, but even as recently as a couple of months ago, there was another round of this is going to go away, and we need to advocate for it. And also, obviously publishing research and disseminating the work that we're doing. It doesn't have to be in high-profile journals. This is actually the New England Journal Catalyst, which is almost really, I shouldn't say a newsletter, but something that is not the same as the New England Journal, but you can kind of publish things about your process. Why did you do this? How are you doing it? And it's a little bit more about implementation, but we can cite this a lot, and it's been very helpful. And this is our whole team of leadership from Penn Medicine on Demand. So a couple other initiatives I want to highlight. Despite the fact that you might have heard in the last year overdose deaths have gone down slightly in Philadelphia, they actually have gone up in the zip codes highlighted here. So these are the zip codes around our 3 hospitals, essentially in West Philadelphia. Hupp, Cedar, and Presby, where there's been actually a 25% increase in overdose deaths in the Black community. So we formed a community advisory board. This work has been led by one of our community members, one of our navigators who is from the community. And she basically has gotten groups of community leaders together regularly to, hear what their concerns are, to hear how we can be more appropriate in providing substance use treatment to our community. People don't want to stand online outside of a mobile van and have everybody know their business if, somebody's trying to get substance use treatment. And they really prefer, like the telehealth, the privacy of telehealth, or the privacy of going to a primary care practice where they might also get their, hypertension treated, and their, families may get other treatment there, and just having substance use care integrated into primary care. So we're learning a lot, and we're trying to incorporate those principles into new initiatives that we lead in the community. One of the other things that we do is twice a week, our team is out at the SEPTA stations at 52nd Street, at 69th Street, and at the Blackwell Library, essentially giving out Narcan, engaging patients in the community, letting them know about our telehealth programs, distributing supplies, snacks, things to just get people more aware of how we can get substance use treatment to their family, friends, and directly to them in some cases. So I think sharing your expertise in little ways and big ways, there's often, for a lot of the work we do, there's often, especially the work in public health, there's often committees around the Philadelphia Department of Public Health or state committees. There was the Mayor's Opioid Task Force several years ago that led a lot of this work in those pivotal years of 2016 to 2020, before COVID's kind of usurped our public health emergency. The FDA has multiple committees on that want experts in being able to review new drug approvals. I was on an FDA advisory committee about drug safety for many years, which also led to a lot of opportunities to collaborate with leaders across the country, similarly with opportunities to work with the CDC. Some of that led to an invitation last May to testify at a U.S. Senate hearing about what's happening with the fentanyl crisis, how we can intervene to disrupt some of the challenges, Narcan distribution. Do we need higher doses of naloxone? What else could we be doing? A lot of it evolved into talk about, fortifying the borders, which obviously is not the solution, in my opinion. But it was really a wonderful experience, and really interesting to be on the front lines of how government is addressing this. In the background, there's my daughter, who actually was working in Washington, D.C. at the time. So that was kind of fun to, be able to, have a guest join that. Just want to highlight all the people at Penn and all the things that we can do to collaborate. I have maybe to a fault, sort of guilt about answering emails from students who want to get involved. Increasingly, that age, was previously medical students, now it's undergraduate students. But just to highlight, I recently answered an email from a Penn freshman who wanted to get involved. I met with him, and it turned out he, as a high school student, had done AI evaluations of imaging for prostate biopsies. So, he was an engineering student. He was, obviously brilliant, as most of them are. And so we came up with a project where, if you're familiar with xylazine, the wounds and the association of xylazine wounds to whether or not patients need to be admitted to the hospital, what kind of antibiotics they need, whether or not it really is a xylazine wound or a different kind of soft tissue injury. So he actually came up with wrote an AI program looking at a library of xylazine wounds to determine, basically be able to predict on a new image whether or not this wound is consistent with xylazine. And that was submitted for publication, and we're also going to try and integrate some of that into Penn Chart. This is a Penn freshman doing this work in collaboration with some of my ID colleagues and some of my IT colleagues, but it's just amazing, the talent across our university. I also want to highlight these three young women who won the President's Engagement Prize. They were three Penn seniors who applied for a prize. They had done a lot of work with harm reduction in a group called the Student Harm Reduction Coalition while they were in school, and they applied for this with the goal of creating a program that would support patients while they're in the hospital, making them more comfortable in the longer hospitalization. So they have actually created a volunteer program specifically targeting to sitting with patients who are hospitalized for substance use disorders at Presby. They bring them iPads, they bring them, Game Boys. They actually have also helped to establish, along with one of our peers, a recovery meeting that happens amongst all of the peers that work in the hospital and all of the patients who are hospitalized at both HUP and Presby weekly in order to sort of realize, all the people who are in the same boat and who people can learn from along their recovery journey. So these three young women are amazing. They're pre-med, and it's wonderful that Penn has given them this year financially supporting their project, and they each get a stipend to live on while they prepare to go to medical school. So it's been exciting to work with them. And again, they're just so, seeing a gap and trying to fill it with their own kind of innovative ideas. Penn put on a forum when Amy Gutman was the president, called the Sylphin Forum. That was Joe Biden, Jeb Bush, and the mayor. And so we had a talk about opioid overprescribing and how to get people into treatment from the emergency department. I was representing Penn on that panel. It was a real honor and led to a lot of other things that have propagated support for my work. And then on Instagram, my daughter, I guess, or my son posted this. So these are the kinds of things that are kind of fun when you bring your family into your work. So, in summary, Penn is an amazing community of brilliant, like-minded professionals. Collaboration and de-siloing can offset the workload, make it more fun and visible, and really help move things to completion. And again, multidisciplinary teams, not just our physician colleagues. There are so many people who have contributed to this work and who really feel passionate about it. And, I think the de-siloing component of this, when it was just a few of us doing it, that was, it was helpful to reconnect. But, we have monthly meetings across the health system that just allows us to hear, what our social workers are doing for helping to place patients in places where they can continue to get treatment. Lots of APPs who want to get involved in treatment. We have a fellowship that was started by my colleagues in family medicine. So we train 2 addiction medicine fellows a year now, hoping to grow that to 4 fellows a year. We're starting a consult service at HUP next month. That'll be led by Bridget Durkin, who's addiction medicine fellowship trained and also palliative care trained, and also a Penn medicine resident and Penn medicine student. So, just coming back here to lend her expertise. So that's really exciting. When I started this work, I was one of, I think, the only person who was board certified in addiction medicine. We've brought along many, many people along the way. It's been wonderful to see all of these people integrating addiction medicine into their practice in family medicine and internal medicine. We have a specialist in OBGYN who left our residency, graduated from our residency, went and did a 1-year fellowship in addiction medicine and came back here and is now leading this work through OB. Some of you may not know that we have a specialty clinic called Proud out of family medicine that especially helps patients with substance use disorders in the peripartum period, also takes care of their children. We have a wonderful peer in that program, and that's led by Naveed Roeder from family medicine, Judy Chertok, and Nia from OBGYN. We have Wei Tang, our first ID addiction medicine specialist, who's helped a lot with the xylazine wounds. And I think some of our other ID colleagues who do this work will also become board certified in the next year. So really exciting to see the physician workforce growing. And then these are all of the peers that work for us at the Center for Addiction Medicine and Policy. Wonderful, wonderful advocates, many of them in recovery, really amazing people, honored to work with. So I can stop sharing and we can take questions or thoughts.
I'm happy to start. Hey, Jeanmarie.
Hey,
Uh,
Jesse.
so I was just wondering, I mean, you've been doing this work through like multiple administrations, and then like I know like probably there's going to constantly be questions about like what X, Y, and Z means in the Trump administration. But I mean, since you have experience like having still facilitated the work during that period, I was wondering what direction you see like advocacy going. What are some particular like things that you see being like more viable or like more likely to succeed, considering like the changes that are going to be happening at NIH and HHS and so forth?
Jose, that's a wonderful question. It's very top of mind. Thank you. Um, I'll start with something optimistic, which is the opioid use crisis has been very bipartisan. I think the solutions may look more polarizing, like I mentioned, the wall and those kinds of challenges. But I think this has affected, communities, rural, urban, across the board. And I do think that legislators believe that it's a problem, across the board, and that's helped get us to where we are. The opioid settlement dollars are a huge resource, and that was part of how I convinced the health system that, we needed to have a foothold in this place. The opioid settlement dollars are going to counties and states to be divided up. So we've applied for several opioid settlement dollar grants, including Delaware County, and maybe some in Montgomery County in the future. So looking to kind of other resources, foundations, in order to continue to keep the lights on. It's definitely a concern of ours. And then there are state grants that are probably also funded by opioid settlement dollars where we are putting our some of our efforts because of course we need the money to to keep going, but I think the state grants are a little bit independent, at least at the moment, of some of these federal challenges. But I definitely agree. I didn't mention some of the other work that we're doing on alcohol use disorder, which is incredibly treatable, has mostly been in an abstinence-based model in the past, but naltrexone is something that's highly effective in decreasing people's alcohol use. So that's something that we're starting to prescribe from the emergency department, but is also there's a lot of opportunities from other funding agencies to be able to go after alcohol use as a equivalent problem that causes many deaths in over a different kind of time frame. But that's a great question, and we're really worried. So you can help us think about how to solve that.
Awesome, thank you.
And Hillary mentioned public health professionals. I actually, I work very closely with many people who have masters in public health. My first research coordinator that I was able to hire a few years ago went through the MPH program, Brittany Salerno. She was one of the most wonderful just people and advocates that I've ever really learned from and had the privilege to work with. And so, yes, that's an oversight in specificity, but MPH students absolutely have been wonderful and motivated and great partners in this as well.
I was thinking of Brittany. Brittany was amazing. You lost her to Montgomery County.
I know.
I have a question. What are your thoughts about the increase in marijuana use and any issues that you see there?
That's another excellent question. I think my usual answer is that as a parent and as a person growing up in this era, liberalizing marijuana use has been a disaster that I don't think was necessarily predictable. But it normalizes an illicit substance so that teenagers in that pre-experimentation, those experimentation years, often leads to this is not illegal. How can you be angry about ABC? And then they just have to elevate it. So it's similar with alcohol, right? Kids who are using a lot of alcohol, if that wasn't discouraged by parents in those very formative years, I think then the students and the teenagers escalate their use to the next thing. So if we don't kind of keep these things under wraps, as substance use in general is a problem, I think normalizing marijuana use has been really terrible and has led to much more escalation at earlier ages to opioids. Obviously, you used to, when people came home from the Vietnam War, people often said this to me. that many people came home from the Vietnam War and they were cured of their opioid use disorder. I mean, they weren't cured of their opioid use disorder, but just the availability of opioids in rural America, wasn't there. So, if you were fortunate enough to come back to a regular suburb, it was pretty hard to continue opioid use. Now, that all changed, obviously, when we put opioids in everyone's prescription medication cabinet, and that led to a lot of experimentation that to this day again goes from a little bit of too much marijuana use or alcohol use to let me try that Percocet. I just use it, when I took a test and I feel like, I did well, sort of um, that ability for young people to rationalize their substance use and to be unaware, especially if their alcohol and marijuana use has been easy to control, their opioid use won't be so easy to control. But people don't understand that differential.
Jean-Marie, in terms of career development, when you think of when you started this work, you were essentially saying things that may not have gone with the tide of belief or what people thought was scientific. And what kept you brave enough and clear enough to persevere? Because now when you talk about it, it's like, oh, that's obvious. But when you started, I know it wasn't obvious because I remember it. So I'm curious about that piece because I think there are a lot of people on this call who have equally observed things that they're trying to change, and yet it may be feeling against the tide.
Absolutely. That, I gave a talk for Focus, I think in like 2013 or 14, and we were just kind of forming coalitions of bigger groups that were allowed to speak out against the Joint Commission and these things. Of course, there's been many books and documentaries now, so it's easier. But in 2009, actually, there was a group called Physicians for Responsible Opioid Prescribing that was started, and I never joined because I was, like you said, personally concerned about challenges. But I followed all of their work. I knew all of them, and they were basically starting the evidence against Purdue and the Joint Commission and all of these groups as a pretty strong body. They had leaders from Stanford and NYU and some other big schools, but they were going against the tide, and they made a lot of accusations against pain physicians who were overprescribing, some of whom ultimately either lost their license or were criminally persecuted. So it wasn't very popular in the beginning, but it was the observations of myself and many other emergency physicians in my era, where we were seeing people come to the hospital, 4 times in a month for, to get Dilaudid for their headache. And, what we learned from those Percocet 4 packs is the nurses would tell us that, the patients took them all as they walked out the door and, dropped the 4 pack in the ambulance bay. So that, people really, there was a lot of drive to get to opioids, and that our overprescribing wasn't really helping anyone. So like I said, it really helped to de-silo this work, to find colleagues across other institutions. I'm looking at Courtney because I know that Corey, you've faced similar challenges in your advocacy. It's hard to be a solo person, and you get so much momentum when there's a lot of other people at a lot of from a lot of other systems to be able to help stand behind you. But it was difficult, and I had my own concerns about speaking out too loudly in the beginning.
So there's a question in the chat from Ping. Thanks for sharing your inspiring journey. What do you see as the challenges ahead in the substance use field, and how can we help as colleagues?
That's great. I mean, at the moment, thanks, Ping. This one will be for you. At the moment, we like just over the past 2 or 3 months, we're seeing a new withdrawal syndrome where I think there's xylazine in the fentanyl, and we saw the wounds. We didn't really see so much of a different kind of withdrawal associated with xylazine, but we're now seeing this new veterinary anesthetic called medetomidine, which is related to dexmedetomidine, which is used in the ICUs. And so that's being mixed into the fentanyl. And we think that the patients who are coming in are actually withdrawing from fentanyl, which we kind of know how to manage, but they're now also withdrawing from this other sedative. And it's really creating a very different syndrome. People are very tachycardic, very hypertensive. They're going to the ICUs. And what we need is drug testing, rapid drug testing, to be able to confirm that that's what the patients are using so that we can, leverage our ability to manage it. Right now, it's just a hypothesis. And I've spoken to many people in the lab about, we have 10 urine samples sitting in the lab. We're going to probably end up sending them out to somewhere else to get confirmation so that we can issue an MMWR about what we're seeing. So I guess more rapid laboratory diagnostics, more drug checking, sort of more bedside to translational work. Most of my work has been informed by my own observations as a clinician. And so I think getting that out there, when we see something new, it's really important to be able to work quickly. That timeline has shrunk, but we need it to shrink a little bit more.
Yeah, definitely. Thank you, Jeanmarie. So, yeah, I've seen the methytomating story in the newsletter headlines as well. So just FYI, if you don't know, I think Jefferson has a mass spec assay for it set up. I think it's a research assay. My colleague there has looked at the urine samples he collected over the last several months. He was looking for methytomating specifically and xylazine. Of course, you can predict that he saw lots of xylazine, but he didn't see one single methytomating, which kind of discouraged him from further pursuing the study. But, with your observation, I think this may be additional evidence we should further pursue. So, as always, very happy to work together.
Thank you so much. I think, we saw some overdoses in the first few, like May to August, that were atypical. And so there were some clusters where we were looking for metatomitin in those overdoses. But this withdrawal syndrome is newer. I have been speaking to the people at Jefferson, but not the lab. So thank you. That'll be helpful. But, being responsive to these changes where everybody, can be rapidly involved is important. And the state is trying to do similar things, but, it's hard to move all these pieces. But it does happen. When you look at my career over many years, you see lots of things have changed, but sometimes it feels like change is too slow.
Yep, absolutely.
Any other questions?
I know I see Judy Chertok on. I don't know, Judy, if you want to say anything. You've been an amazing colleague, and it's been wonderful to, partner across primary care with you. Sorry.
Oh, thanks for the shout out. I'm in the car. I'm on the way to see some patients. But my only comment is just a thank you for your mentorship. And I know lots of people here have benefited from that. But just as someone more junior, it's just really great to have people who are passionate about the work, who push you to do things outside your comfort zone. And then, can continue to help along the way. So for anybody who's, mid-career like I am, finding people to mentor who have been through it has been incredibly useful. And so I thank you for that.
Thanks, Judy. Thank you.
I second that because I've watched Jeanmarie mentor a lot of people in this arena and serve as a role model of people who want to make change. So thank you so much, Jeanmarie.
Thank you, Jeanmarie. Yeah, I mean, I think your story is just such an incredible one of like persistence and keeping your focus and eye on like knowing that the impact that you can make and trusting your gut on what's right. And it's such a great story to tell people because we all have those moments of like, I don't know, I'm out here by myself or whatever. And your story is such an extraordinary example of just keep fighting that fight and finding the strength within yourself, to keep up the work. And now you're doing work that instead of trying to say what feels like an incredibly challenging message to be heard and understood, you can flip it so that and push the envelope in all new ways. And that's just amazing. So we all have so much to learn from you. Thank you.
Thanks, Corey. Appreciate it.
Thank you so much, Jeanmarie. Take good